Thank you very much, sir. A very good morning to all of you. It's a privilege to be here. As has already been told, I'm talking about management of submacular hemorrhage, which is something which can be quite debilitating for a patient once he has it. Suddenly the central vision gets lost in these patients. And it could range from a small submacular hemorrhage to something quite large and significantly blocking. So these are medium-sized hemorrhages that very often all of us have seen in patients, sometimes with polypoidal, sometimes with AMD, that you might see these patients. And the typical way we would manage them is to diagnose the hemorrhage as a subretinal hemorrhage and then do a fluorescein ICG, which ICG sometimes helps you see if it's polypoidal or has a hot spot and helps you align the treatment better, because we usually would give anti-VEGF injections, but then if you also see a hot spot which is extrafoveal, you can also do laser to those areas to reduce the number of final injections and also give gas tamponade. So such a situation which you see here has been treated with gas tamponade and intravitreal injection, and you'll see that as the time passes, the hemorrhage gets displaced from the macula and the patient starts recovering the vision back as the time progresses. So you can have fairly good outcomes with these medium-sized hemorrhages if it predictably clears up the vision. In the past, we used to many times do surgical removal of some of these membranes. Mind you, this was in the era before the anti-VEGF, and there if we had a classic membrane well defined, we would go and remove these membranes, because otherwise the only other alternative was to do a laser to them, which would distinctly bring down the vision right away. But of course, removal of the membrane also used to leave behind scarring at that particular site. So these are some of the examples of the older times, the photos from the past that some of our cases we used to see, and this is pre and post removal. And I think removal used to benefit them because from a long-term perspective, if you could remove a nice classic membrane, the bleeding would stop and even the damage is minimized to a smaller area. In fact, we published some data on membrane removals once the anti-VEGFs came, as in to try and see whether after treatment with an anti-VEGF, the removal of the membrane used to cause lesser bleeding when you would cause it, lesser tendency to bleed, because anti-VEGFs would have already checked on some part of the neovascular component. This is just again an example from some of our older files when the anti-VEGFs had just come, and initially the patients used to be reluctant to take more than 1, 2, 3, and then this is an example of a patient where we had given a few injections and then the patient was reluctant, and then we went in and removed the surgical membrane. So the typical way to do is to make a small nick and then go with this special subretinal removal forceps, which was designed earlier where it was common. It had this long beak which would allow you to ergonomically go and gradually pull the membrane out of that particular area. And this would work quite well for small membranes. Of course, if it's a large membrane, then of course your retinotomy has to be larger and you would cause more damage. But the smaller membranes could be removed very predictably in a fine manner and with reasonably good results. And then just put some perfluorocarbon to give pressure on these areas. But then you come to this area, which is a huge, you can see the size and the thickness of the blood. Now these are hemorrhages which can be devastating for the patient. They suddenly have lost all vision in that eye. And I don't think just a gas injection or anti-VEGFs is really going to make much change. The blood keeps getting organized, dehemoglobinized, and leads to a large scar. The other eye of this patient showed something like this. So you can only imagine when the patient came to us with the better eye getting that hemorrhage, how worried, anxious with just hand movements, vision is there. So in such a situation, we decided to undertake surgery, wherein the aim is to, of course, first remove all the vitreous, all the adhesions. The hyaloid has to be removed from the attachments which are there. And you can see that the expanse of the blood, it's almost causing a detachment inferiorly because of gravitationally the weight of the blood, which itself leads to that. So we first create a PVD, make sure the vitreous is out and remove all the connections there. And then assess the extent of the blood with an aim that we want to do a retinectomy in the periphery, in the temporal periphery, so that we could evert the flap and then go and debulk this blood, because there's no way to debulk it, just like I showed you with the removal of the membrane. This size of a blood cannot be removed through a small posterior or a large posterior retinectomy, which would be very damaging. So what you see here is that we are doing almost like a 200-degree diathermy in anticipation of a retinectomy, so that we can evert that whole flap without a bleeding. So we carefully diathermize all the large vessels as well as areas which we feel might bleed, and then carefully cut that whole retina. This PFCL was only to give stability to the posterior pole, and also to see that the blood, does it shift with the perfluorocarbon, but it didn't. So now we've done this retinectomy, and we are everting the flap so that we get a good exposure of the blood, because that's the only way you can remove such a large chunk of blood which is thick and organized, instead of trying to remove it through smaller openings. So carefully we remove the attachment of the retina from the underlying blood as much as possible, and then you also see we use partly, at times we use bimanuality also if required, because you have a flappy mobile retina and then you want to use your cutter inside. So that's up to whatever ergonomics are good at that particular stage. But the idea is to keep the flap everted and then remove and debulk this whole blood. So you can see that the whole chunk is actually pretty much one full unit, because it has clotted over a period of time. And gradually with some patients we kind of remove it from the overlying as well as underlying tissue, and then is eaten up. Now in this particular situation, the membrane itself was not very calcified, because maybe it was not that old, but at times we have seen that it can be very calcific, and the removal can take a lot of time because of the calcification nature. Now you can see that the last bit of the blood is coming out from that area. And once we are sure that we've removed most of that blood, then basically you treat it like a giant retinal tear. Now you need to put perfluorocarbon and re-evert the whole flap back, so that you can confirm that whatever was intended has been removed. So you see slowly the retina going back, and all you are left behind is this small central area. Of course, that is a damage which you can't prevent, because that's where the original membrane was, which is usually sub RPE. So whatever you remove will remove the RPE from there and lead to a central damage. But still, the amount of blood which was there suddenly goes off and leads to a lot of visual rehab. The patient came to us with hand movements and was 636 in a few days, and was very happy and relieved, because he's already lost his other eye to a similar situation. This was sometime post-op, and you can see the gross comparative pre and post of the same patient. This is after about 8 months that we removed the oil, and here you'll appreciate better the central scar in this patient which forms. So you can see that the oil is being removed, but now you can see the organized scar is seen much better here, because that time it was fresh, the pigmentation had not happened. So this is like a remnant of a central membrane, but the patient still retains his 636 vision so far, delving between 636 to 660, and is quite happy with his mobility. You can see the peripheral scar's retina is well aligned. And a similar situation of another case where we had done a similar thing. This is again pretty much the same approach, just a different side of the eye, and then we remove the vitreous and then approach the hemorrhage. I'll just fast forward it to take you through the important steps. And we've made the retinectomy, again done the same procedure. We use a spatula here to help you just evert the flap. And here again, once you see that we are able to remove that big chunk of the collected hemorrhage, which is clotted, as well as the organized membrane, which is a part of this whole complex which is there. So gradually all that is eaten up. And these small gauge cutters, even though the port is small, they are very efficient. They surprisingly are efficient with the way they can remove these membranes, which otherwise, even with the earlier 20 gauge, we used to sometimes find tough removing these. So you can see the bare choroid here, and the membrane has gone, and then now we are again putting the perfluorocarbon to gradually flatten out that area, so the central area is debulked to a large extent. This is the post-op of this patient, and you can see the comparative changes which are there. So the gross bulk of the blood, in fact, it's almost like a detached retina with the instead of a serous fluid, it's a hemorrhagic fluid which has detached the retina, and the debulking helps a lot in these patients. These are just some pictures on the follow-up of these patients over a month or two. This patient still requires an oil removal. The other one we removed oil some time back. Thank you very much.